And this is the patient CT scan. And if you look at the X-ray on the left lower lobe, the patient having blunting of the costoperonic angle, and also within the cardiac border, you could see that there's a cardiac cavity there with air fluid levels. And that's illustrated on the CT scan. The blood results, which was done on the patient, HB was about 11.8, white cells was slightly elevated. However, the eosinophils was extremely high, which was about 2.55. CRP was also elevated. Sputum by fire was negative. And the question that, what test do you want? So today I want to discuss about approach to eosinophilic lung disease. So the overall learning objective of the discussion, is, of course, to review the major eosinophilic pulmonary disorders and to be able to distinguish an acute and chronic eosinophilic pneumonia, and also to be familiar with the common presentation of acute eosinophilic pneumonia, chronic eosinophilic pneumonia, allergic bronchopulmonary aspergillosis, and eosinophilic granulomatosis with meningitis, and then, of course, the Sachs-Strauss syndrome previously, and hypereosinophilic syndrome. Let's start. So first, we need to understand eosinophilia. Eosinophilia contain granules. Granule contain the what we call major basic proteins, and also eosinophilic cationic proteins, and also eosinophilic-driven neurotoxins. And not forgetting the charcoal-laden crustal proteins, okay? And also eosinophilia does produce cytokine, and of course the cytokine that stimulate growth, differentiation, and production of eosinophilia, such as IL-5, IL-3, EMS, CSF, and also IL-5 specific for eosinophilia. So definitions, of course, eosinophilic pneumonia, a heterozygous group of disorder characteristic by increased numbers of eosinophilia in one or more compartments of the lungs or bloods. And then, of course, they have radiographic abnormalities. And then on the pulmonary function, they'll have impaired pulmonary function tests. They will have positive or negative peripheral eosinophilia, and the role of eosinophilia in many of those diseases differs, and it's not well characteristic. You have the good guys beside the bad guys, without the bystanders, as demonstrated on the presentation here. These are the good guys when eosinophilia act to defend you against parasites, and of course the bad guys is when you're having eosinophilia actually attacks your lungs. And then the bystanders of obvious inflammation like rheumatoid arthritis, where the eosinophils are produced as a result of the different kind of pathophysiology completely. So the classifications of classification based on anatomical. Obviously, when you look at eosinophilic disease, we look at the airway, such as in asthma, eosinophilic bronchitis, allergic bronchopulmonary aspergillosis, and also bronchocentric granulomatosis, or parenchymal disease, such as idiopathic or non-cause. So obviously, the idea that when you have patient with a high eosinophilia on your full blood count, you need to look at two ways how to actually make sure the diagnosis. You have to classify as airway, means basically really your bronchi, and then you're up to really terminal bronchi, and obviously then you look at the parenchyma, which is mostly the consolidations and others. Okay. So that's why asthma probably is one of them, and then you also do the eosinophilic bronchitis, but we'll elaborate in more details. So let's look at the primary eosinophilic disorder. Of course, we have the limited lung-limited disease, such as acute eosinophilic pneumonia and chronic eosinophilic pneumonia. And then, of course, those that involve systemic, that would be your hypereosinophilic syndromes, eosinophilic granulomatosis with meningitis, or Sachs-Strauss. Secondary eosinophilic disorders, this results from the primary, and those will be, of course, classified as airway centered, such as allergic bronchopulmonary aspergillosis, infectious, such as parasites, bacteria, fungal, such as aspergillus, and then, of course, not forgetting the vasculitis, and then drugs or toxin use. Malignancies such as lymphoma, lung cancer, leukemia, myelodysplasia syndromes also can contribute to the development of eosinophilic secondary eosinophilic disorders. And of course, also interstitial lung disease, such as hypersensitive pneumonitis, Langerhans cell histiocytosis, not forgetting, of course, cryptogenic organizing pneumonia and sarcoidosis. They're also known cause secondary eosinophilia disorders. Let's have a look at allergic bronchopulmonary aspergillosis or allergic bronchopulmonary mycosis. And this is really quite a common disorder. We're seeing quite a context in the context of pulmonology. And one of them is really the pathophysiology. It's involved the hypersensitivity to inhale fungal antigens. Doesn't meet normally you don't have the aspergillus itself, but just really the inhalation of fungal, the antigens that are really involved. And usually, but not always aspergillus, but could be any other fungal. And 2 to 14% of asthmatic older patients will have them, and 1 to 15% of cystic fibrosis patients. And of course, males with lower lung functions. And how the diagnosis? Of course, the diagnosis of the diagnostic criteria for ABPA, it's of course the patient must have, you have major criteria and minor criteria. The major criteria, of course, you have to be asthmatic with a positive immediately hypersensitivity skin test to aspergillus, serum precipitant to aspergillus, and IgE of more than 1,000 nanogram per ml, and also elevated serum anti-aspergillus, fumigatus, IgE and IgG, pulmonary opacities, eosinophilia on your peripheral blood, and the positive or negative proximal bronchiectasis. The minor criteria, of course, is mucus plaque with aspergillus and dual cutaneous reaction to aspergillus. And of course, the stages, aspergillus stages, they have about 5 stages. One of stage 1, when you're having acute elevated IgE, asthma, eosinophilia, opacities with precipitating antibodies. Stage 2, when you have remissions of symptom resolution, reduced IgE. And stage 3, when you have an exacerbation with increased IgE and symptoms recurrency. And stage 4, steroid-dependent asthma with elevated IgE levels. And stage 5, when you develop fibrotic lung disease. Radiologically, you could see that the patient always, most of these patients will have like, when you look there, it's quite the patient having atelectasis with the quite thickened bronchi with the mucus plaques on it. And probably much more clear on your CT scan. And when you CT scan, you see what we see, the finger in globe with a quite widened your bronchi. So other things that look for radiology, of course, they will have what we call transit opacities, upper lobe predominate, finger in globe, and mucoid infarctions, and not forgetting proximal or central bronchiectasis. And if you look at just the pointer there on the CT on the CT scan on lower lobe. And this is really quite classic pictures of the patients with ABPA. And most of these patients, of course, pathologically, you see as a mucoid infarction, bronchocentric canal inflammations with eosinophilia, lymphocyte and plasma cells, and then immunogenic normally. And the treatment normally, it's really we tend to give them corticosteroid, such as itraconazole for 16 weeks. Voriconazole has also been used. Standard asthma treatment is always recommended, probably with high inhaled steroid, and also limited evidence for omalizumab, which is normally in this patient really I haven't experienced with it, and I think probably it's most of my patients that they need to use that. And then let's look at the second issues, the Lupol syndromes, okay, which is a simple pulmonary eosinophilias, which is normally caused by parasites as Ascaris, worms, and they tend to present really with fever, cough, wheezing, dyspnea, and rare hemoptysis. Of course, they have peripheral eosinophilia, chest X-ray. They tend to have migratory opacities. Diagnosis, rarely parasite in respiratory secretion. You are unlikely to find it. And then pathology, they tend to have eosinophilic infiltrates, and treatment tend to be quite self-limited. And in terms of strongyloids, somebody have a good treatment for that. And then parasitic infections, which is most likely, again, you find in most of the countries, especially around the Nile, where you have a lot of worms like Sanocare, strangulates. In South Africa, not forgetting about Echinococcus, and of course, the list goes endlessly. And the pathophysiology, of course, involves the direct invasions, immunogenic reactions, and transpulmonary passage and seeding of the parasite larvae. And then pulmonary symptoms, of course, they tend to have cough, wheezing, and also they might have GI symptoms. And then, of course, in patients with paragonomyosis, of course, you will have eosinophilic pleural effusions. And this is, of course, the paragonomyosis, of course, where you have a direct parenchymal invasion rather than briefly passes through the lungs and en route to GIT. And of course, you got recurrent, those patients tend to have recurrent hemoptysis, and then you have chocolate color sputums, peripheral eosinophilia in early stage, and eosinophilic pleural effusions. Chest X-ray, they will have peripheral nodular lesions with the ground glass, commonly on mid and lower zones. And then on the radiology, on the diagnosis, of course, aches in the sputum or bronchoalveolar lavage with positive LAs. And then treatment is parasequantal for pulmonary infection. And then tropic pulmonary eosinophilia, that's tend to be geographic, endemic to India and Africa, and also Asia. Malaria related, of course, with the with immune response. Most of these patients tend to have nocturnal cough, fever, weight loss, malaise, dyspnea, wheezing, and chest pain. And chest X-ray, they tend to have what we call granulosa opacity in 20%. And they tend to have refractory asthma, patient going from one or what we call uncontrolled asthma. And then some patients will have cardiac and CNS involvement, which can be rare, but it's there. And then peripheral eosinophilia with elevated IgE levels. Bronchial lavage, you'll see eosinophilia, and the treatment is really by diethyl carbamazepine. Strongyloids, I think I was very unfortunate to have that during my childhood in South Sudan, and they tend to also have auto-infections, tend to be immunocompromised host, but I think I was young that time, the age of 7. And then they present, of course, I remember that you cough, wheezing, dyspnea, fever, and hemoptysis. Chest X-ray, opacity that can progress to ARDS. I didn't know whether they have opacity or not, but anyway, the patient will have peripheral eosinophilia. Diagnosis obviously in bronchoalveolar lavage. Transbronchial biopsy is always indicated. We see aches and lava. Allergia, IgE. Treatments, antiparasitic drugs, or ivermectin. That's the only time it's indicated, not in covered, guys. The other pulmonary infection associated with eosinophilia, of course, will be pulmonary coccidioidomycosis, and then pulmonary micromycosis and disseminated Staphylococcus with TB, very rare. Medications, of course, medications are also known to cause eosinophilia. Those, of course, will be ranging from antibiotics such as daptomycin, ASA, of course, not forgetting amiodarone, which we use commonly in ICU, cocaine inhalations, heroin inhalation, and also common drugs that are used in rheumatoid arthritis, such as methotrexate, phenytoin, of course, in epileptic patients, and of course, the most common is nitrofurantoin that tend to be used in elderly people with recurrent urinary tract infections, and not forgetting the NSAID and SSRI, which is more common use in America because almost everybody's on that. On those patients, of course, drug-induced acute eosinophilic pneumonias, medications are a common recognizing cause of the eosinophilic pneumonia. The diagnosis requires the presence of at least a febrile illness of less than 5 days with a diffuse bilateral pulmonary opacities. They tend to be hypoxic, and then bronchoalveolar lavage demonstrate 25% eosinophilic pneumonias on the lung biopsy. Drug-induced acute eosinophilic pneumonias, of course, additional the diagnosis of drugs-induced eosinophilic pneumonia require exposure to candidate drugs in appropriate time frame, exclusion of infections caused by eosinophilic pulmonary opacities, and the clinical improvement after cessation of the medication, and recurrence of finding upon challenging with the drugs, which is probably, I think, sometimes if you're not vigilant enough, you might actually miss it. Antimicrobial agents and non-steroidal anti-inflammatory medication mostly commonly associated with this condition. Daptomycin, I think, currently being discontinued, but we know that there's quite a few generics that currently being in use, but we have seen quite a few patients with that. Of course, in July 2010, the U.S. Food and Drug Administration issued a warning about the risk of developing eosinophilic pneumonia during treatment with daptomycin, and perhaps that was the reason at the beginning the drug was withdrawn. The idiopathic acute eosinophilic pneumonia also can be very severe, tend to be younger, slight male predominancy for whatever reason, and usually healthy, associated with recurrent onset of smoking, and then thus environmental stimulus, and then of course was evidenced quite the number of children increased during the World Trade Center, and of course with the new e-cigarette usage also, tend to have acute onsets. Let's look at the idiopathic acute eosinophilic pneumonia, because the diagnosis will be based on acute febrile illness of less than 5 to 7 days in durations with a cough, malaise. They tend to have hypoxic respiratory failure, and then diffuse alveolar or mixed alveolar or interstitial opacity on the chest imaging, bronchial alveolar lavage showing eosinophilia more than 25% or can be nearly less 50%, and this absence of parasite or fungal infections, drugs of asthma, rapid and complete resolution to steroids, ready to have a peripheral eosinophilia, at least area. That's really what you see. And then, of course, as acute eosinophilic pneumonia, which is quite perhaps much common, chest X-ray, you see PET opacity, ARDS, small effusion in 2/3 of the cases. On pathology, you see eosinophilia in alveolar and also bronchial walls. And also within in the interstitium, sometimes they present the diffuse alveolar damage, what we call that. With elevated bronchial alveolar lavage or IL-5, vascular endothelial growth factors, and IL-8, and serum IgE. Treatment, of course, corticosteroids is a cornerstone in 2 to 8 weeks, usually complete and rapid response. Relapse is very rare. And then chronic eosinophilic pneumonia tend to be middle-aged women, non-smokers, and 1/3 to half with atopy, 60%, asthma in 50%. They tend to have subacute chronic presentations, weeks to months, with a cough, fever, sweat, weight loss, dyspnea, and wheezing. And in the country where TB is endemic or quite the TB is a problem, you always most of these patients tend to they tend to be started on pre-TB treatment and be treated as TB, and of course the condition will progress. And we see what we clinicians that have a high index of suspicions to make sure that they don't diagnose. And if you look at the radiologically, it tends to be more upper and low predominate, and obviously in countries like South Africa or Sub-Saharan Africa, everybody would think that was TB related. And the giveaway, of course, they tend to have peripheral blood eosinophilia, more than 30% in nearly 90% of cases. And also on the bronchial alveolar lavage, they will have eosinophilias of over 30 to 40% with elevated IgE in 50% of cases. And pulmonary function tests will show evidence of would be mixed obstruction restricted or normal lung function. And this is very evident. You will see a CT scan. And obviously now, if you look at it radiologically, in the past, you will be confident to diagnose that as probably eosinophilic pneumonia. But since 2020, you have to always think about covert pneumonia, because covert clinical also present almost the same radiologically with the basal kind of involvement. So always make sure that you exclude covert pneumonia. And then chronic eosinophilic pneumonias, radiologically, of course, we see non-resolving pneumonia, tend to be peripheral, pleural-based, dense with ground glass opacity, and what you call photographic negative of pulmonary edema in less than 50% of cases. And that's, as I said, how we exclude covert. And pathology, you will have eosinophilic infiltrates in alveolar space, interstitium, And bronchiolitis obliterans, much common pattern. And then they might have microabscesses with non-causating granulomas. Chronic eosinophilic pneumonia. Eosinophilia is likely a pathogen with IL 5, 6, and 10 with elevated IgA. Treatment, of course, is corticosteroid for 3 to 6 months, improve over hours to days. Relapse is common in 1/3 to half in 50% of the cases. And this is really a table to postulate the difference between acute eosinophilic pneumonia and chronic eosinophilic pneumonias. In acuity, of course, acute tend to be acute severe with less than 5 to 7 days of symptoms, while in chronic tend to be milder with weeks to months. Asthma is really would present some of the acute cases, but in most cases, probably none, while in the chronic tend to be about 30 to 60%. Blood eosinophilia is absent acute eosinophilic pneumonia, which make it difficult to diagnose within the general practitioner or even physician rooms, but it's more really tend to be more pulmonologist diagnosis, and in chronic mild to moderate. Bronchoalveolar lavage, which will be done by pulmonology or cardiothoracics. Of course, you will see that the patient will have quite high levels of eosinophilia, and also the same as chronic eosinophilic pneumonia will be very high. The only distinction, of course, will become radiologically in the time and the presence of asthma. Chest X-ray, you see diffuse ground glands opacity, and then pleural effusions. While in the chronic eosinophilic pneumonia, you end seeing peripheral consolidations. Treatment, corticosteroid, rarely relapse, while with the acute form, you would have corticosteroid common with a common relapse. Let's look at idiopathic hypereosinophilic syndromes. Of course, tend to be younger, middle-aged males, and tend to be with a range of severities, and tend to be multisystemic system affected, lung 40%, cardiac, skin, GIT, neurological symptoms, with a unchecked level of IL-5. Diagnosis, you tend to have eosinophilia, which unexplained for more than 1,500 for 3 to 6 months, or on 2 examinations, with more than 1 month apart, with end organ dysfunctions. Treatment, of course, there is corticosteroid with variable response. And this would be trials of interferon gamma alpha, chemotherapy, or drugs as hydroxyurea or biological. And then eosinophilic granulomatosis with cholangitis, that's what we see quite commonly. And this is really normally seen by pulmonologists and rheumatologists, and of course, ENT sometimes. And previous was known as Sachs-Ross syndromes. They tend to present with allergic granulomatosis and angiitis, rarely 2 to 7.7 million a year, age between 38 to 50 years, but we've seen younger, with male more than female ratio. They tend to present with really necrotizing eosinophilic vasculitis and tend to have subacute onset. In my practice, I think we have about between 10 to 15 patients. And they tend to present in 3 phases. Most of them, they present as asthmatics with predominant of about 8 to 10 years. So most of these patients will be treated as asthmatics because they will present with a symptom allergic rhinitis and atopy in most of the cases. And then in second phase of presentation, will be eosinophilic peripheral and tissue eosinophilia with lung, GIT, and skin involvement. And then the third phase will be vasculitis, such as necrotizing vasculitis of small and medium vessels, extravascular granulomas with constitutional symptoms. But again, most of the time really depend how they present. You find that you might actually find that they present with eosinophilic peripheral or vasculitic instead of the asthmatic. So EGPA clinical finding, of course, they tend to be asthmatic in 99 to 100% of cases. And then peripheral nerves, 75% with mononeuritis multiplex. That's when they're present in neurologists or orthopedics. And they will have sinus disease, 70%. That's not picked up by ENT, or they probably most of the time being treated as chronic sinusitis. That's why it's very important to do anchor on most of the patients with the recurrent sinusitis. That's with no evidence of allergies. Skins, 50% with papilla, nodules, and petechiae, and that again can be mistaken for platelet dysfunctions. Lungs, 38 to 58%, they will have opacities, fusion, and diffuse alveolar hemorrhage is rare in less than 3%. And again, with the lungs, again, most of the time the opacity can be mistaken for TB, non-benign lesions, and then obviously not forgetting other fungal infections. GIT in 30% of cases. Kidney, they can have about 20% involvement with acute interstitial nephritis or focal segmented glomerulonephritis. Heart, 12% with congested heart failure, cardiomyopathy, and most of them tend to be either from heart failure with reduced ejection fraction, most common. In central nervous system, 10%, and some of the symptoms just relatively constitutional. So EGPA diagnosed, of course, you need presence of 4 to 6 criteria. They need to have asthma, peripheral eosinophilia more than 10% or more than 1,500, paranasal sinus abnormalities, mononeuropathy or drop foot or polyneuropathy, migratory pulmonary opacities such as nodules, ground clots, opacity, and cavitation. Then, of course, we've got extravascular eosinophilias on biopsy. This is eosinophilic vasculitis. EGPA, of course, pathophysiologists tend to be immune-mediated with a peripheral eosinophilia. Bronchoalveolar lavage, they tend to have eosinophilia with elevated IgE levels. The P ANCA and myeloperoxidase ANCA is positive in 40 to 60% of cases and may correlate with vasculitis. But just remember, in 40 to 60%, that means in 40%, it might be negative. So that does not exclude absence of P ANCA does not exclude presence of the EGPA. Then, of course, ANCA negative, correlated with eosinophilic infiltrate and cardiac. So you have to look at a constellation of symptoms. That's why there's a criteria. Pathophysiology, pathology, most of these patients might need the lung biopsies, and then you see interstitial eosinophilic tissue infiltrates with necrotizing vasculitis of small to medium vessels, granulomatosis. So it's part of really ANCA-associated vasculitis. EGPA, most of them, they have leukotriene receptor antagonists, tend to patient because most of these patients will be on the leukotriene receptor antagonists because we always want to stabilize the nasal mast cells. And unfortunately, that it tend to unmask EGPA as steroids are decreased with the leukotriene antagonists. It tend to be casual, and other drugs may do this also, inhaled steroid and omalizumab. The treatments for prognosis, if untreated, corticosteroid still remain a cornerstone. Maintenance with rituximab, azathioprine, methotrexate, and of course, you can use mepolizumab, which is always indicated. Relapse is quite very common. In severe refractory disease, cyclophosphamide, rituximab is always indicated, and in some cases, the role of plasmapheresis. Assessment, of course, you look at 5 factor score with 0 to 2 with 1.0 factors. Age more than 65, involvement of cardiac, renal, GIT system, absence of ENT involvement. Use for severe or life-threatening organ involvement, heart, CNS, mononeuritis, and renal. So basically, you have your game changer for treatment. You want to see whether it's organ limited or systemic. And then on the last of eosinophilic disease, of course, would be non-asthmatic eosinophilic bronchitis. The cause of chronic cough, very common. Patients coming to GPs, chronic cough, most patients be exposed to a lot of different treatment with no improvement. And most of these patients really have no radiological finding, no variable airway obstruction, no airway hyperresponsiveness on the metacolline challenge test. Eosinophilic presence in the sputum or pulmonary alveolar lavage. And they tend to respond to corticosteroid, treatment inhaled corticosteroid. And this really sometimes can be a very difficult diagnosis, especially with if you don't have a good blood samples test, and also if you in the center that they cannot do bronchoscopy. And this was our patients. Our patients have echinococcus with high eosinophilia, and it's quite very known. That's a very common in South Africa, in Eastern Cape, and also in most of the Limpopo. with the farmers start farming pigs. Thank you very much for listening. So the summary of the key points, of course, will be mainly disorder in this group of disease will be the non-acute eosinophilic pneumonia, besides the chronic eosinophilic pneumonia, ABPA, eosinophilic granulomatosis, with pharyngitis, hypereosinophilic syndrome. We know also which disease usually have peripheral besides from the alveolar lavage, eosinophilia, or both, and most are corticosteroid respond. And this is really more key probably for the pulmonology fellows in training. Thank you.
Thank you very much. Any questions? We're going to be. There's 9 people. Is there any questions from anyone who's online?
The fellows online, I see quite a few of them there. All right, if there's no question, we want to say thank you guys for listening. I think we have our next presentation tomorrow by Prof. Michelle Wong. Please, we want you guys to join, and then let's listen to her. It's going to be one of the best presentations. And the title of the topic is obesity and asthma. Is it a matter of egg, the chicken, or both? So looking forward to hear from you guys tomorrow. Anybody change their mind about questions? No?
Some comments.
All right. Thank you. Then we can
Thank you.
stop. Yeah.